We're a little ahead of schedule, and that's a good thing because it gives you more chance to come to the fore. I did want to make a comment about the workforce. We mentioned something about ratios, and I've learned that the operative ratio when you're talking to any healthcare professional is it's 1 to everybody else, and it's it's hard to find a number that is optimal because it's really always overwhelming. And that we talked about an urgent need for certain classifications of workers, and I think there is one thing I also know is that there's an urgent need for mental health assistance in the form of counselors and other things, not for the patients, but for the professionals. I think that's clearly a need. But let's turn for our commenters and our dissentants and questioners, and please identify yourself and give a direct question.
Thank you. Ellen Hodnett. For Dr. Bingham, I have a kind of research suggestion A1 might want to get behind and a question. But first, I'll just say I hope to see you in Nashville in June.
You will see me, and I thank you for submitting an abstract. Yeah.
Thank you. You're talking about staffing in labor and delivery units really struck a chord with me because it's been a pet peeve of mine ever since I was a nurse manager of a labor and delivery unit. Of course, they're staffed typically, not all of them, but typically based upon an average patient census. And anybody who's ever worked in one knows women have this nasty habit of not coming in an average kind of way, and you get these peaks and valleys of workload and times of, as you've alluded to, unsafety, and other times when nurses are sitting around with nothing to do, and it drives, cost people crazy. When we conducted the nursing skill trial, we addressed that head on because we wanted all women in the experimental group to have one-to-one continuous support, and said, you have to rethink how you're staffing these units. And there are different ways to do that, but I'd love to see somebody take some of that forward. For example, single room maternity units, not unlike the critical care and step-down unit that photograph that Dr. Sternberg showed earlier today, allow for, you can predict the total obstetrical census in a hospital with much greater accuracy on a given shift than you can where they are, whether they're in labor or postpartum. And I would have to think that probably women don't see themselves as divided between having a labor and having a baby afterwards. So single room maternity care, the so-called cross-training of nurses and so on, looking at that as a way to deal with both satisfaction, safety, and cost seems to me, an area that needs more research exploration. And then my question was, I was intrigued when you mentioned the possibility of RNs filling a gap in home births, and I wondered what it is an RN might do that a midwife isn't already doing for a woman who chooses a home birth.
Yeah, well, thank you first for your work, and definitely has been very informative. And those of you who are not aware, in most recently the Cochrane review that summarized the importance of support in labor and improvement in outcomes. And I know that wasn't shown to be the case if it was as likely to be the case if they were a hospital employee. But I think there's more to unpack in those types of studies. As far as home birth and nurses, it's hard because we have so little data on how nurses actually spend their time. But we do know from the work and all that some of the things that happen at hospitals, and in fact some of the unfunded, perhaps public health initiatives that fall on nurses, such as hearing screening, cardiovascular screening, and other types of screening tests or immunization teaching. We don't have a way to know if those things will be continued on in a home birth setting. So I think it's just an important question to ask if are there things that we are missing in nursing care in a home birth, so that we need to understand what the nurses do in hospitals that we want to replicate in a home birth setting. Some things we may not want to replicate. So,
Thank you.
Now we'll switch to the other side of the room. Everybody get a little bit of exercise. Spinal flexion here.
Thank you. My name is Ida Debra. I'm a certified professional midwife, and I'd like to thank all three speakers for very, very interesting presentations this afternoon. My question is for Catherine, particularly because you're from California, because you're from UCSF, and UCSF has such a history of involvement in the health professions and in research for the health profession. So I think it's almost a microcosm of the United States in looking at these teams of various professionals who work together to provide maternity care. So it's a great place to do some research. California has physicians, certified nurse midwives, and certified professional midwives all providing care. There are a lot of providers, so there's a lot of opportunity to look at what they're doing and how it's working, and to look at the relevance of regulation, education, and licensure on this workforce. It's all there in California, so it's perfect. You have major, dense urban areas, sprawling urban areas, and vast areas where there's not anybody at all. So you can address all those factors that affect access to care based on all those conditions. I think it would be just a great place to look at how the teamwork of these providers in all these areas impacts the kind of care that's given, and especially would relate to so many questions that Susan brought together at the end that need to be looked at in terms of how all of the maternity care providers are providing optimum care and teamwork to provide the best options for the mothers. Thank you.
Great suggestion. I will work on that. Thank you.
Oh, we'll jump quick. And
Quick. Claudia Booker, certified professional midwife. I think that's a wonderful thing. The National Association of Birth Centers and Clinics of Color that has most of its board based in California. It consists of roughly seven birth centers owned by midwives of color. One in the Bay Area, one in Compton, one near San Diego. Are all certified professional midwives licensed in California who have not been able to find a doctor to sign a collaborative agreement with them so they can take Medicaid clients and help serve these communities of women of color that we're having a hard time catching in our statistics with better outcomes. You would be salsa on Friday night. You would be the jiggity if you could help work those issues, Ida, because exactly where you are in California is where the women of color and the midwives of color and the birth centers of color are having the most difficult time coming up with a collaborative relationship.
I hear you. Thank you. Well, let's talk offline. Thanks.
okay, yes.
Holly Kennedy, Yale University and the American College of Nurse Midwives. So thank you all for a very interesting presentation. I actually have many questions, but I'll try to hold it down to a comment and then a question. I think Catherine really exposed the confusion we have about providers in terms of not knowing how many there are, all the alphabet soup that we deal with, and the real strong need to get a handle on that and to do it nationally. And I'm proud to report that the 7 midwifery organizations in the United States that look at accreditation, certification, and association are working very hard together on that to try to come to a place where we can help the country look at that. But second, Debra, I'm intrigued by the issue of staffing ratio in terms of outcome, and I would bring us back to what outcomes are we looking at. There are several studies that have looked at how nurses perceive a pregnant woman as ill or well and how that's related to outcomes. So it comes, and what are the skills that nurses need, that midwives need, that obstetricians need that make a difference. And for example, in terms of you were talking about evidence, simply taking a low-risk woman and never putting her on a monitor and never putting her in bed requires a different staffing ratio, but it has a different outcome. And so I wonder if AWAN is looking at that in terms of future research, in terms of how we apply the evidence in how we care for women in hospitals.
Yes, indeed. In fact, we have now specified 9 nursing care quality measures, and we've had a panel working on that for the last year. That will be going out for public comment in the next few weeks. And what that focuses on is the independent care practices of an RN. RNs work in a team, and they have both independent and collaborative practice. And there are many ways in which a nurse in the United States has complete autonomy over the care they provide, such as many of the items that Carol Sakala had in her, that she showed on her slide, where getting women out of bed, you know, walking around, the types of coping and supportive measures, those are all within the purview of the registered nurse. And so this data, this set of quality measures is a beginning. And it's trying to look at those process of care, particularly those around independent nursing practice. So one of the measures that we will be introducing for public comment is non-directed pushing, for example. Another quality measure will be skin to skin immediately after birth, and another one will be continuous skin to skin and measuring the length of time. Some around perinatal bereavement, transfer of a newborn. So when those come out, we would welcome, those will be out on they will be on our website. We will welcome public comment to that. Much more work will need to be done. They will be draft, and we'll need to have funding to be able to have those validated and tested in the United States. Yes.
Thank you, Debra.
Sutton.
This is Elliot Main from the California Maternal Quality Care Collaborative, and I want to commend all 3 of you for this very important yet very confusing topic of workforce. You know, how we're going to all work together is a very challenging issue. How recently in my unit in San Francisco, we've had several moms who've had a nurse care for them in labor, a doula with them, a midwife, and a physician in backup. 4 providers for birth, that's not sustainable in any kind of an economic model. As we look toward, you know, cost containment, even though some of those were paid for privately. So it is confusing as to what happens. When you look at midwife units in France or England, where there's a lot of midwife-driven births, my understanding, and I've been to both countries, is mostly it's done by midwives without labor nurses. That's a very different model than the United States. And I'm not quite sure how all those fit together. And I'd like to ask all of your opinion as to where we go to optimize the workforce.
I'll start, but you guys chime in. I would say my comments about team certainly didn't mean that everybody would be on the team full time. I mean, that would be lovely for all of us to have a team of 4 or 5 people working with us during labor. It'd be great, but we can't afford it, and it probably isn't even that good for us. But I meant that there would be possible components to a team that might be chiming in at various points during the whole pregnancy, throughout the entire period, and including labor and delivery. But I completely agree with you that I think there are better models out there that some groups are looking at now, you know, that are alternatives to the physician-centric team leader model, and that does include the midwives being the leader, and possibly calling on some other other people, other professionals and paraprofessionals to work with them during the labor and delivery. But there are some good models out there, and I think people are thinking about it, you know, being driven by some of those factors that I mentioned. So it's everything from trying to improve quality of care, to trying to save money, to looking at better integrated care, to even trying to improve the what's the word? You know, the staffing satisfaction and their contentment with their jobs, because that's a big issue right now too. We've seen a lot of turnover and recruitment challenges in some places because people are not happy with the way things are working out because of this lack of good teamwork. So I agree with you that there are good models out there that we could look to for different from what we have right now, but I also think that the team can be thought a little bit more expansively. Somewhere during the entire pregnancy, you would tap into everybody from the mental health professional to the midwife to the doula to the community health worker who could track, and you might have many more touches with the healthcare system, but much shorter touches, which is what we're seeing in primary care as well.
Let's go on to the next questioner. We've got, if everybody's going to do it, you got 2 minutes per exchange for us to finish at 5. So,
Larry Lehman from the American Academy of Family Physicians and University of New Mexico. My questions and comments both address rural maternity care, which I don't think is an area that we've really talked about very much today, and is really quite different. And Catherine, my comment would be, I think it's really important to track rural providers. It's often family medicine docs doing OB there, and look at them as their own category. They're often the surgical providers, and I think that information is important and needed. My question for Debra is as I go through, my state's very rural. I work a lot with Indian Health Service and all. Nursing is such a big issue for us, and we don't have the luxury of, in a lot of these places, of actually even having a dedicated obstetrical nurses. We have to have nurses that work in emergency rooms, and then they come over for the one birth a day. And I just wanted to ask you whether there's any thoughts on research or programs to really deal with the issue of maternity care in more of a generalist way for rural settings.
As you may have seen, our data collaborative did include hospitals with less than 500 births. And I do also go out and help evaluate the Indian Health Service hospitals right now. So and have worked in a hospital where there are only a couple of nurses on duty. So we are looking, any of our guidelines are not only for a high volume hospital setting. And we are looking to and learning from those settings what works for them, and have models of how they can orient staff without having that expertise necessarily in-house. We have orientation programs that are pre-programmed so that they don't so they could learn from experts without having that expert in-house. But we do, exactly how, and those models would be very flexible. So it's just a matter of competence, that they need to have the competence. They can do more than one role at a time, but you have to have a certain level of competence to do the surveillance, monitoring, and mobilization of the team.
Good. Thank you. I think some of it goes back maybe to training, where people don't see the model in their training that they can be something other than purely a labor and delivery nurse, that they could do a generalist rural practice.
Yeah.
okay, yes.
Hi, Kathy Rule from A1, also a nurse midwife. And with both my hats on, I'm always honored to be able to see a broader picture than I might have otherwise. So I want to underscore and just pull together a point that we cannot say too much, which is the impact that our overuse of oxytocin has on nursing staff. And I think all of us know that nurses run Pitocin. They administer Pitocin. That's their role. Pitocin's a high alert medication. As Debra mentioned, this is why we recommended a 1-to-1 ratio. It's also a high contributor to liability. And when A1 did before we published our staffing guidelines, we asked our members one question, which was, what would they offer us to include about staffing? And we got 897 responses. And there was a real theme throughout about the heavy burden of oxytocin. And we know that our medical reasons for induction are certainly, until we improve women's health before and between pregnancies, are not going to substantially decrease. So I don't know if there's a response to be said, but I think we can't emphasize it enough.
Okay. For those making statements without a question, so finish up with a little uptone, like it sounds like a question, and it'll go good. So, yes.
I have a real question.
Yeah, good. No, it's okay. Statements are good, but just kind of
Okay.
Well,
I mean,
yeah.
as far as these large care teams go, though, I will say that most women I know would prefer not to have 4 or 5 people in the room while they're having a baby. But I wanted to ask about pain because that came up in the last set of presentations and also in your slide, you know, talking about no pain being a criteria for the nursing. And for most of what you were talking about, it seemed that more interventions necessitated more nursing care, you know, if there was Pitocin administered. But when you have, you know, when you're giving people pharmaceutically induced pain relief, how does that change the ratio of nursing staff? And how are nurses in OB, are they trained to look at pain differently, or is this threshold of no pain being the goal really something that cuts across obstetric nursing and other kinds of nursing?
The pain, the women without epidurals, the staffing ratio is actually recommended ratio is 1-to-1, so that there would be a nurse with
Right.
that woman, and that's what you saw is not being met. So our nurses having adequate training and orientation around non-pharmacological methods of labor support. I would say that I don't have data on that other than anecdotal data, and I would say that that is limited. The amount of knowledge in that area we could definitely improve on, and we are actually working on that at A1. Now, some of it is once we put together evidence-based guidelines, anyone who studied the diffusion of innovations within healthcare know it takes about 17 years.
No, I'm at the Center for Medicare and Medicaid Innovation. We're into rapid cycle improvement. 3-year turnaround. Let's go.
Let's work on it together. So in this case, A1 has had evidence-based guidelines for a number of years, let me just put it that way, that have promoted what we're talking about. But that has the measurement of whether that's integrated consistently into nursing practice, we don't have measures on that, nor do we think that those have been adequately diffused within the workforce.
I'd love to talk with you about this offline.
Perfect.
Okay. Yes, Susan.
I just want to clarify the collaborative teams does not mean that all of those people are in the room for the birth. That would be way not cost effective.
Okay, yes.
Saraswati Vedam, I just wanted to add to what we do know from the research that's there. I have been the principal investigator of 2 national studies, one in the United States of certified nurse midwives, and one in Canada, recently finished with a multidisciplinary group of co-investigators on multidisciplinary maternity care providers and the development, what leads to their attitudes around birthplace. So the Canadian Birthplace Study, which I've just finished, and there are several publications forthcoming as well as already out, which do lend weight and certainly have quite a bit of evidence that education and exposure absolutely lead. It's a pretty, we did a logistic regression. We have a scale, a validated scale. It's not just, it's covariates, it's not just bivariates. It is absolutely leads to attitude development, to interprofessional comfort with interprofessional collaboration, to confidence across birth settings, and to knowledge and confidence with physiologic birth care. So education and exposure for health professionals, and that would include nurses, of course.
Yes.
Betsy Armstrong, Princeton University. Reflecting on some of the demographic data that we saw this morning about the changing composition of U.S. women who give birth, it seems that there's another potential gap or mismatch in the maternity care workforce, which is what the people who provide maternity care look like compared with the people who are giving birth. And I would love to hear from the panelists about any initiatives to diversify the maternity care workforce in terms of the kinds of people who choose to enter these different professions.
Well, that's a very tough question in this area. There's so in medicine, the gender split is, or the gender mix is better now. There's been some efforts over the past 30 years, 40 years. So we're getting better in terms of gender in medicine. Gender in nursing, it's not much better. It's minor improvement, so there's a little bit more male representation, but it is mostly female. Racial and ethnicity, terrible representation overall. I mean, it's just that's a problem in all the health professions, but it's particularly acute in this area for some reason. And I do not know the reason. And I don't know that there have been some, actually I'm looking around because I don't know if somebody's done any research on that. So I don't know the answer. I know that some people, it's on their radar screen, but I don't know of any hard data about the reasons for it, nor any strong efforts to really change it right now, any major initiatives. I don't know. I mean, I know that many of the associations, it's on their platform now to address it. Future of Nursing included a number of private or smaller associations are working on it, but I don't know of any data.
Let me comment on that. There are racial and ethnic distributions among professionals that are very different. And we've done work in North Carolina where we look at the various professions and show how diverse they are. And so you see the second most diverse is physicians. The least diverse is nurse practitioners. That's the kind of thing that people are not aware of. And we know that these are things that are problematic in the system. But it's information that has to be there. That's another thing about what Catherine said. We don't have the data that says, we barely know how many there are, approximately, but who they are is another thing. Yes.
Yes, I'm Judith Lothian. I'm a nursing professor at Seton Hall University, and thank you, Deb, for your presentation on nursing. Although I have also just am winding down a qualitative study of home birth in New York City. And part of our issue, I think, is that those of us who haven't been around home births really don't know what goes on and what it's really like. So for me, it's been an eye-opener over the last 2.5 years to actually be at home births. And my sense, teaching undergraduate maternity students, is that if they could spend more time at home births, they would be much better nurses. That indeed we are seeing evidence-based, quote, nursing care happening there. So if indeed registered nurses had a role at home births, it would be doing the kind of old-fashioned nursing that many of us were brought up on, of being there for women, getting to know women well, providing the kind of continuous emotional and physical support that nurses taking care of IV drips and post-op cesarean mothers don't have time to do. So I think that things like hearing tests and blood pressures and all that stuff gets done, but that's not the important work of nurses. Anyway, I just had to say that.
Thank you so much for fixing my bad answer. Because you're right. I mean, I had said to you the essence of nursing is caring relationships. And it really is the truth.
And Catherine.
If I could just add to that, because one thing I skipped over on my simple chart of education, it's only CPMs, to my knowledge, that must demonstrate competence in all settings. So doctors and nurses, most everybody else have to, they learn the hospital setting primarily. And with CNMs, you might learn a little bit in the other settings, but the CPMs have to demonstrate competence in all settings. Is that accurate? Oh, I'm sorry. In the home birth, because the question was about the home birth. So they need to demonstrate, and they do train and understand the home birth setting. So I just want to comment on that. And I think there are, I know, oops, let others comment on this too.
Okay.
Mari
Only
Roth-
one person is going to go if we're going to meet by 5. So, no. You haven't had your chance here. Yeah. No.
Yeah, can we both go?
Oh, well,
Yeah, come
go
on.
ahead, both. I mean.
I will be brief. Mari Rothman, I just wanted to say I started out my nursing career as a birth assistant for home birth and birth center midwives. And it's great being a nurse at a home birth. I think a good birth assistant doesn't necessarily have to be a nurse, but a nurse can be a very good birth assistant.
I do want to also underscore Kathy Rule's point earlier that your comment makes that point. The nurses are frustrated in how the way in which care has evolved in a hospital setting at this point. And Kathy Rule's work in that area, helping bring that data to the forefront, is very important work. And so thank you for pointing that out.
So
the last word.
All right. Oh. Two things. I'll make two last words.
Two
So,
last words.
I just want to comment on what Judy Lothian said. If every single person attending a woman at birth understood what a birth facilitated by the woman's own capacities, which happens more often at home. I mean, in terms, there is no, there is less intervention in her own environment. We would all begin to trust birth in a different way. That being said, that can happen in the hospital too. It absolutely can happen in the hospital. So to clarify, Catherine, about the preparation of midwives, and this is part of, there are confusing issues about this. And I didn't want to address that slide. I was going to talk to you about the one slide about who's prepared and what. Nurse midwives and certified midwives, as Pat clarified, most of our education is in hospital. There's no question about that. Some of us are able to provide our students with birth center birth, and some of us are able to provide our students with home birth experience. But we can't necessarily get it all because of multiple reasons. It would be too numerous to go into. It is a problem, though, in terms of being able to prepare everybody. Regardless, though, I can speak to nurse midwife programs and certified midwife programs, is that we do help students look through, if you're in a hospital and you have this, what would happen if you were at home? What would happen if you were in a birth center? So helping them work that through. I don't want to speak for the certified professional midwives, but my understanding is you are experts in home births. That's where your training is, but you're not certified in hospital births, right? Can I just clarify that? Okay. That they observe several hospital births, but so we have a variety of ways of preparing people, and it is confusing, but I felt we needed to clarify that.
Okay. Well, thank you very much, Maxine, and we'll close our session for the day.
Well, let's thank this panel for their wonderful work. I can certainly speak for everyone in this room. This today has exceeded all of our expectations in terms of how we would deliver on the content, and it's been incredible. I am going to also acknowledge the audience, and let me thank you for your staying with us all day, and for your questions. And I invite all of you back tomorrow, and I hope you will join us in this room tomorrow at 9 o'clock for 3 more panels, the content of which I think will be just as stimulating as today's content was. So we expect for you to be here bright and early in the morning, 9 o'clock, for another very good session. Thank you very much for today, though. Thank you.